This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 889, recorded on April 14th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today, right here at the incubator, Daniel Griffin.
Hello, everyone.
Good to see you here in person, Daniel.
Yeah, it's nice to be here in person. This is, and we have a lot to talk about today. Can you imagine that?
All right, well, it's update number 110. Let's have it.
All right, let me start with our quotation because we've got a lot to cover. So, anti-intellectualism has been a constant thread winding its way through our political and cultural life, nurtured by the false notion that democracy means my ignorance is just as good as your knowledge. And that was Isaac Asimov, and what could he possibly have been talking about? As far as updates, we are seeing a rise in the number of cases in our immediate tri-state area. Our 7-day average here in New York is already approaching 6,000 new cases per day. This is already higher than it ever was during the Delta wave. So just to give people perspective, I'm going to sort of close with a little bit of words of warning about behavior around the holidays. Because I don't know, Vincent, there's this rumor that this has nothing to do with behavior and it's all variant driven, but I am going to challenge that and suggest that we have some control here and there's choices we can make to keep ourselves and our loved ones safe during the holidays that a lot of people will be enjoying when they listen to this.
Daniel, what are these tests for? Are they in people with symptoms or are they random screening tests? Do we know?
So it's a mix, and I do get some sort of on the ground real-time data out of our urgent care centers, about 100 of those in the tri-state area, just sort of ProHealth Riverside, ProHealth Connecticut. And one of our centers just on Tuesday alone, 30 people came in. 18 of them were for symptomatic respiratory, all COVID positive. Actually, I will mention that 5 of them had flu, and actually 80% of the people with flu were co-infected COVID and flu. So, some people are coming in because they're not feeling well, they're symptomatic. That's mainly what we're seeing in our urgent care centers. People who are doing at-home testing because of an exposure, we're not even counting those. So that 6,000 is, I'm going to say, an underestimation.
And what fraction of these 6,000 are actually severe deaths?
So that's the big difference. People keep saying, hospitalization, deaths, those are lagging indicators. I'm hoping they're not lagging indicators. I am hoping that the combination of, recent prior infection, immunization, so vaccination, which is really significant in our level, is going to really prevent us from having significant hospitalization and death numbers this time around. There is a little bit of a bump. I just was admitting another person and actually going to run back out to the hospital this evening to see a new admission. So starting to get a few of them end up in the hospital. But these are going to be either your unvaccinated or you're a person who's at high risk who couldn't quite get that protection from the vaccine or has a lot of other things going on. All right. Nice article I want to start with here, and it's right in our update before we get into our sections. And this was the article, Symptom Prevalence, Duration, and Risk of Hospital Admission in Individuals Infected with SARS-CoV-2 during periods of Omicron and Delta variant dominance. A prospective observational study from the ZOE COVID study. This was published in The Lancet. So some of our listeners probably familiar. We've discussed the ZOE project before. It's a very helpful prospective observational resource. And we do really need to spend some time looking over the figures, tables, and text in this article before making too sweeping generalizations, because I think that the media sort of made some sweeping generalizations. And I'll go through, what's the data say? What are people saying? So, for instance, they say, we're seeing more sore throats with Omicron than we saw with Delta. Well, 70% versus 60%. So, yeah, that is true that sore throat is more common, but 70 versus 60, it's not big from a clinical perspective. Also touted as, loss of smell went from 50% to 20%, But then we've got 25% of people with Omicron saying they have altered smell. So, there are differences in terms of symptoms, symptom duration that are statistically significant at a population level. But I really urge people to go and look at this figure. Actually, I've got it up in front of me right now. And you could sort of go through, you're like, oh, headache, statistically significant. It went from like 75 to 79, but the confidence intervals aren't overlapping. Or, you find something a little bit more dramatic like the loss of smell, but we're still seeing it, as I mentioned, diarrhea, very similar. So I think this just reinforces that, you can't tell what variant a person has. You really can't even tell what virus a person has without getting in there with a test. And they did report a shorter duration of symptoms, but again, they themselves say their data suggests that this may just reflect vaccination status.
That graph is very nice because you look at it and you go, oh, it looks similar for Omicron and Delta with the exception of smell and maybe brain fog. They're slightly lower for Omicron, but everything else is similar, wouldn't you say?
It really is. And if you then go from loss of smell over to altered smell, you're like, well, actually, when you start adding those, you're kind of losing, So in an individual patient, it's very hard to tell.
Yeah.
All right. Also, right up front here, the paper, Infectious Viral Load in Unvaccinated and Vaccinated Individuals Infected with Ancestral Delta or Omicron, SARS-CoV-2. So we've got ancestral, Delta, and the Omicron variants of concern. This was published in Nature Medicine. And I'm just going to hit with a few highlights. First, they start by commenting that, and I'm going to quote here, infectious viral load expelled as droplets and aerosols by infected individuals partly determines SARS-CoV-2 transmission. So I'm going to say I think we start with one of the biggest science communication issues of the pandemic. I'll say failings. This whole idea that droplets versus aerosol is some absolute binary, and that somehow you can get that 6 feet apart in a closed space, and somehow that's going to be fine. I'll save this for later discussion, but just we need different terminology. We don't need to be fighting about, is it droplet, is it aerosol? We actually need better terminology, and we need to really focus on what we know, which is, boy, if you're in an indoor space and there isn't good ventilation, far enough away, there is no far enough away. Second, RNA measured. I love this one. RNA measured by RT-PCR is only a weak proxy for infectiousness. Vincent, you want to jump in on this? I think that's...
So we actually did this paper on TWiV as a preprint several months ago, right? And it hit all the buttons that we've been hitting for the last 2 years, because this is one of the first groups to do infectivity. Nobody else does infectivity. And so, yeah, you learn things, like you said, PCR is a weak proxy for infectiousness, so it's a really good paper.
Yeah, it is a really good paper. And I like one of the figures where they really show, you can't just look at the RNA copy number. You need to know things like, where are we in the course of disease? Is this, within the first 4 days when we're isolating this? You can't just look at a PCR number. You can't just say, oh my gosh, the test is still positive at day 9. They must be teeming with virus. RNA is not infectious virus. There were a couple other interesting things I will say. In the study, the authors quantified infectious viral load. They did it properly in SARS-CoV-2 infected individuals during the first 5 symptomatic days. They looked at unvaccinated or vaccinated individuals, and they found a couple interesting things when you looked at different variants of concern. And I'm going to say that's sort of going to be a theme that we've got to keep thinking about in the future. Time matters, but it also matters which variant are we discussing. So they found that unvaccinated individuals infected with pre-variant of concern SARS-CoV-2, so that's our ancestral, had lower infectious viral load compared to Delta-infected unvaccinated individuals. For Omicron, reduced infectious viral load was only observed in this study in boosted but not in unboosted fully vaccinated individuals compared to unvaccinated subjects. So we've got Omicron, we've got Delta, we've got pre-Delta. We have comparison of vaccinated and unvaccinated. All right. Children, COVID, and other vulnerable populations. Children are at risk of COVID. As of 4/7/22, so I keep track of this each week. You're always a little bit delayed in getting the data. We were up to 966 children that have died so far from COVID here in the US. So 966, almost 1,000 children. We are finally down to less than one pediatric death per day. We have not been down to that level since early November. So what a horrible winter, and what a horrible, this is Omicron, right? So
how can people, Daniel, say we don't need to vaccinate kids?
I don't think they're looking at the data. I mean, you know, we have lost almost 1,000 children, and almost all of these were preventable with vaccines. So we need to protect our children. Yeah. All right. Testing. Never miss an opportunity to test. Don't forget that a patient can have two things at the same time. A positive flu test does not rule out COVID. A positive COVID test does not rule out flu. I see these articles about all the mechanics of why people can't have both at the same time. You know what? If you only test for COVID, you're not going to have a positive flu test. If you only test for the flu and you're not allowed to order a COVID test, you're not going to see the co-infections. We are seeing plenty of co-infections because we're not restrained. We can actually go ahead, we can test for both. And as I mentioned, 80% of the flu cases seen in that one day also had COVID. And I think I described early on at one of our urgent care centers in like early March 2020, and this was a friend of mine who, you know, hey, the flu test is positive, starts to take off the gear. That family also had COVID. So one of the concerns we have is there is some data suggesting that individuals with co-infection, flu and COVID, are at higher risk of progression. Also, remember, we now have treatments for COVID and flu, so we actually have times when we're treating for both. I kind of thought we were good on testing, but I continue to get lots of questions, so apparently I've got to keep talking about this. Maybe this will save me a few texts and phone calls in the coming week. But let's go through where are we and what's new. So we discussed the article, predictive value of isolated symptoms for diagnosis of SARS-CoV-2 infection in children tested during peak circulation of the Delta variant. And this is much like the paper we discussed right up front. You really can't just rely on symptoms to know what variant a person has or really what viral syndrome is in front of you. So we really need testing. The other, and this is the important discussion, comparison of rapid antigen test performance during Delta and Omicron variants of concern, secondary analysis from a serial home self-testing study. This is this whole myth out there that, oh, these rapid tests don't work as well during Omicron. And as we discussed, when we looked at correlation to a positive PCR, we were getting a positive rapid antigen test within 48 hours, 79% of the time with Delta, 89.5, almost 90% of the time with Omicron. No suggestion that the rapid tests are failing us in the detection of Omicron. If anything, we have a little bit of a challenge with a bit of overdiagnosis of COVID, and I think this is important to revisit. Molecular tests, such as those PCR tests, the Abbott ID Now that we do in some of our centers, the molecular tests can stay positive for up to 12 weeks, 90 days. So this is something we run into in our urgent cares, but we also see it a bit in the hospitals. Now, in the hospital, it's a bit easier. I can just put in a special request, run it on that machine where I can get CT values. I could say, boy, we have a documented infection here in, let's say, January, early February. Now we've got a CT value of 38, 39. It's easy for us to sort that out. But that's one of the challenges for us as clinicians because things can stay positive at these molecular sensitivity levels. And I want to bring sort of a real life story into this. So this is a patient that I'm taking care of in the hospital right now. I'm quite concerned about this individual. Immunocompromised, initially got admitted with RSV, so it was RSV positive, COVID negative, took care of him in the hospital. He improved, felt better, had his negative departure COVID test. I guess that's our thing now. He was then at home, and about a week later started to feel poorly, increased trouble breathing. This progressed. He developed bilateral pulmonary infiltrates. Oxygen level dropped down to 85%, elevated neutrophil lymphocyte ratio, comes into the ER, and his PCR is now positive for COVID, still positive for RSV. And I want to make that point, still positive for RSV. The molecular test staying positive is not new for COVID. This might be something new for clinicians, not necessarily seeing and thinking about this before. And also, we did not have as great access to these molecular tests before. But what would I have thought if I didn't have the molecular tests from before and from now? I would have thought, this acute issue now was RSV and COVID. I wouldn't have known that COVID was probably original. I might have wondered, did I miss COVID, a couple weeks ago? So one of the things to be thinking about, what are we trying to do? What's the timing and what's the best test for that? The other issue, I'm going to talk about the correlation between antigen positive tests and infectiousness. A negative antigen test is very reassuring, right, for a person not being infectious, but a positive PCR or antigen test does not mean a person is still infectious. And this is not just for COVID. This is something we've been discussing for a while. So particularly in a vaccinated person, there's little documented transmission past the first 4 days from symptom onset, and very low success of culturing virus after that period. So I hear a lot of buzz out there. This person has a positive antigen test on day 9. How can they possibly be out circulating in the world? Remember, that is a positive antigen test. That is not a positive test for infectiousness or viral isolation.
I think part of the problem is that early on when these antigen tests were released, people were saying, oh, these are going to be positive only if you're infectious. And that turned out not to be correct, as you just said.
Yeah. They're better than PCR. So instead of a 90-day window of staying positive,
yes,
at least it's smaller. But no, you can still have a positive antigen test even after you've left that infectious zone.
So that's a good point. 4 days post-symptom onset, you're not likely to be transmitting anymore, right?
Yeah, and that's kind of the logic behind the CDC. I mean, nothing's 100% except for death, apparently not even Texas. But yeah, I mean, that's when we're seeing, the peak of transmission. Now, you're immunocompromised. There's other parameters that might complicate that. But yeah, it's really that first 4 to 5 days from the time that symptoms onset or the time of that first test that we're seeing our contact tracing evidence of spread. So what are the current recommendations? And I am hoping that, I think of this section as mainly for physicians, for clinicians and providers, but there's a hope that next fall we're actually going to have at-home, not only COVID, but also at-home flu tests. So this will be recommendations. Maybe people can go back to this, but what have we been recommending for flu tests? What have we been recommending for COVID as far as those antigen tests? And this is sort of straight from the CDC, is collect those specimens as early in illness as possible. So ideally less than 4 days from illness onset. But for COVID, right, not within that first 24, you usually want to wait till that second day. Go ahead, follow up those negative results with confirmatory tests if it doesn't make sense, or if you think you might be really early and that's why you're missing it with an antigen test. You can always, again, just go ahead and repeat that antigen the next day for about $10 from a test that you can grab at CVS or Rite Aid or something. And then remember, positive predictive value. If there's a lot of influenza, a lot of COVID going around, you get a positive test, you can hang your hat on that. If there's a lot of influenza and COVID going around, you get a negative test, you've got to ask yourself, does that make sense? Do I want to repeat the test, et cetera?
So remind us, post-exposure, when is the antigen test going to be positive?
So post-exposure, if you are successfully infected, this has changed with the different variants. And I'm going to say it's intrinsic to the virus because some people say, oh, this is pre-existing immunity, this is vaccine, that's what's changed this. I think the data is pretty compelling that with the ancestral Wuhan, it was about 6 to 7 days from the time of exposure before a person would start to test positive. And we've seen that move to shorter and shorter periods of time. So right now, we're about 2 to 3 days from time of exposure when a person starts to have symptoms and starts to test positive.
Antigen tests, right?
Yeah, that would be antigen. And actually, nowadays, with the really rapid increase in the virus, we're seeing a less than probably 12-hour difference between when that molecular test turns positive and when that antigen test turns positive. So much smaller window. Yeah, which actually, I think this is an update, right? Early on when we were doing a lot of our screening, we could do a PCR test the night before, and we really were not having people end up the next day showing up at work and infecting. So we could just sort of do every evening PCRs, and we were about 100% at succeeding in, the movie industry, sports, et cetera. Now you could have a negative PCR the night before, and by the late afternoon the next day, you could already be infectious. So.
Okay.
Yeah, quicker ramp up. All right, the pre-exposure period, I touched on this a little bit. If you want to wear a mask, feel free to wear a mask. I was wearing a mask when I took the train in today. Not everyone was.
I thought it's required on trains.
Yeah, it's required, but
Oh my gosh.
I was watching the conductor to see if he would say anything to this young lady, but he just wanted to make sure she paid her fare. And then the big thing, and I touched on this early on, is there's no binary here. This idea that, it's droplet versus airborne. If you are indoors with a large number of people, that is much higher risk. And so ventilation is huge, and I'm going to just plug again. We need better terminology. I think maybe whatever. We need better terminology here. Let's not go into the next pandemic without updating our language around how different viruses can be transmitted. All right, active vaccination. Never miss an opportunity to vaccinate, and this is a new one. The jabs that protect you from getting very sick, right? We really need to reinforce vaccines. I mean, unless you're going to be vaccinating everyone every 4 months, really the idea that vaccines preventing infection is, I'm not sure, a sustainable end game. But vaccines are traditionally and continue to be very effective at preventing illness, severe disease. And I get a lot of questions about, well, which vaccines? And there's actually a whole list, because I know this has come up in some of our emails, like from another country, and now I'm here in the U.S. So you can actually go to the WHO, and this will probably be in our show notes, giving you a list of what are those vaccines other than Moderna and Pfizer and J&J that we use here in the U.S. that are considered acceptable vaccines. But let me hit on myocarditis, and I've got a couple articles here that I wanted to talk about, because this gets back to the issue. Why are we not vaccinating children? Why in half the counties in our country only 10% of the children are getting vaccinated? There's a fear here, and so let's talk about what's the science. So the article, Myopericarditis following COVID-19 vaccination and non-COVID-19 vaccination, a systemic review and meta-analysis. This was published in The Lancet Respiratory Medicine. And they reported the overall incidence of myocarditis from 22 studies. So we are looking at 405,272,721 vaccine doses. They were seeing about 33.3 cases per million vaccine doses in this huge study. They, at least in this study, did not differ significantly between people who received COVID-19 vaccines and those who received non-COVID-19 vaccines. Sort of an interesting, because we always think about, this is a COVID-19 vaccine issue. When they compared with COVID-19 vaccination, the incidence of myopericarditis significantly higher following smallpox vaccinations. But actually not significantly different after flu vaccinations, or in studies reporting on various other non-smallpox vaccinations. So really kind of interesting. It's really gotten a lot of fire and a lot of press here, but at least looking at, which is pretty robust, 405 million vaccine doses, I think reassuring. And this is the next, and I think this is a critical point that I try to reinforce, is myocarditis following COVID-19 vaccination the same as myocarditis following COVID-19 infection? And so the paper Global Reports of Myocarditis Following COVID-19 Vaccination, a systematic review and meta-analysis, this was posted as a preprint, so we'll maybe get back to this again. In this review, they found that almost all, so 87%, of the cases that we saw occurred after the second vaccine dose, median interval about 3.3 days after that second dose. The most frequent symptoms were chest pain, myalgia, body aches, fever. 93% of the time the symptoms resolved, patient fully recovered. So as we've discussed, not high as far as incidence, but also, these are mostly transient, getting better, quite a bit different than the long-term myocarditis, cardiac issues we see after infection. All right. And just, the CDC has their page of WHO, EUL, emergency use listed vaccines. And these are actually in language that makes sense to me. But I'm looking at this and I'm thinking that that Christine from Scotland can come and visit us now because Novavax is on there. Oh. And they actually make a point that if you got these vaccines in a clinical trial, that's good too. So go there. You've got a lot of options, people coming into the country. Passive vaccination, Evusheld. I'm actually pretty impressed. We seem to be doing a good job here in the tri-state area. Actually, one of our centers, we've used enough that I'm waiting about a week for the next shipment of Evusheld to come in. So, you don't want to be kicking yourself when your immunocompromised person ends up in the hospital because you didn't think to offer them this extra protection. All right, and I'm going to spend a bit of time here. Period of detectable viral replication, viral symptom phase. So now you test positive or your patient tests positive. I really want all the listeners of TWiV to feel very comfortable in this space, knowing what they should do when this happens. So what are the things we don't want to do and what are the things we do want to do? And I'm going to start with avoiding harm, right? Let's not make things worse. So we want to avoid steroids during that first week, during the height of viral replication and prior to the early inflammatory phase, as this may increase the risk of progression, might prolong the viral replication phase, could cause hyperglycemia, increase the risk of other infectious complications. We've talked about this. You can harm your patient with steroids. We want to avoid antibiotics unless there's a secondary bacterial process, which is just not that common. Doxycycline, azithromycin, we've studied those. They are not helpful. They only cause harm. Aspirin, we've looked at that. It's been studied, not helpful. Zinc causes GI distress, not helpful, only harmful. So don't go after these things that we have studied that are not helpful. This is not 2 years ago where you throw darts at a board and hope you gave something, and then when your patient gets better, take credit for it. Do things that help. I do get a question right up front, Dr. Griffin, you keep reinforcing that the therapies that you're about to discuss are only for high-risk individuals, but they're sitting on shelves. Why aren't we giving them to everyone? Perhaps they could make people not at high risk feel better faster. Perhaps they could reduce the risk of long COVID. Maybe if you gave doctors the option of using these, they'd stop handing out heartburn pills, ivermectin, zinc, or Z-Pax. Well, let's go to the Paxlovid study. So for instance, Paxlovid, there is a phase 2/3 EPIC-SR. So this is evaluation of protease inhibition for COVID-19 in standard risk patients. This is a study to evaluate the safety and efficacy in patients with a confirmed diagnosis of SARS-CoV-2 who are at standard risk, so extending this. We currently do not have the data to allow the FDA to open access to this group. At this point, we're not sure what the impact will be on these individuals. We don't know the impact on symptoms. We're learning. We also do not know whether it will prevent long COVID or not, maybe even make it worse. We're not sure. We don't know the impact on contagiousness, and we still don't know the impact on safety. So the data is being collected. It's not that these drugs are being withheld or limited or triaged. We're waiting for the data to know if we should be doing this. All right, so let's go into them now that we've given that background. So positive test. First question, as I mentioned, is this individual, are you at high risk? You determining whether or not you're going to go with treatment or whether or not you're going to avoid harmful things, stay home, take NSAIDs, stay well hydrated, keep in touch with your provider. If you're at high risk, then we start going down the treatment options. Paxlovid, number one. And why do we recommend Paxlovid as number one? Why does the IDSA and the NIH and all the treatment guidelines? Remember, this is an 88 to 89, almost a 90% reduction in progression. It is generally well tolerated. There are some side effects. We may talk about those, but it's low incidence. We're talking about the 1% to 2% range for some of the GI impacts that we sometimes see. We want to be asking what is the kidney function, and we want to be asking what other medicines the person is on. We can always start the drug and then adjust for kidney function once we get the labs back. But you do want to take a moment and look at those drug interactions. You can go ahead and you can go to covid.gov, and then you're going to go to this test to treat locator. You're going to look in your area. You can actually see specifically what pharmacy has Paxlovid. And this is exciting. This week is exciting for me. We are now in our area able to just send an electronic prescription to that pharmacy where we have identified they have a supply of Paxlovid. The electronic systems now help us by checking kidney function. They help us look for drug interactions. But remember, this is really a 90% reduction in progression. And just like on TWiV 888, you can't wait. You can't wait to see if the person's going to get worse. If you wait, you may miss the window. And then at day 6, when that immunocompromised, breast cancer, elderly individual starts to become hypoxic, you missed your opportunity to reduce that by 90%. All right, next. What if for some reason they don't qualify or you can't do this? Bebtelovimab. I want everyone to stop, say this, say it in unison. Bebtelovimab. It's not that hard. This is our current monoclonal antibody. So it's being given in the first week. It's functioning as an antiviral. We're thinking this is in that 85 to 90% efficacy as well. Same issue. We've got it's sitting on shelves. This is a 30-second infusion. You got to get your patients there within this window so that they can get this treatment. Does this impact long COVID? We're not sure, but it certainly does impact progression to hospitalization and risk of death. And what if that person says, I'm just not excited to leave my home? In a lot of parts of the country, you can get at home. You can actually go onto a website. You can get your patient this therapy at home, and it's just MABS, MABSRx.com. There's a locator. If that doesn't help you, then talk to your local providers. This is something we should be making happen. I don't want bebtelovimab sitting on the shelves, with lots of storage when we end up on the next variant and, we haven't used what we had. Remdesivir, this was discussed a bit on 888, TWiV 888. We are doing remdesivir in the outpatient setting. It's really not that hard a lift. You put in an IV, they get 200 milligrams right then. They come back for the next 2 days, 100 milligrams per day. Based on the New England Journal of Medicine article, this is now licensed, approved, 87% reduction in progression if you get it in the first 3 to 5 days. So, viruses act quickly. We've got to respond quickly. And molnupiravir, why is this at the end of the list? Well, it's considered a last option with only about a 30% reduction in progression, so less impressive, but easier to use, no kidney issues, no drug-drug interactions. But remember, you want to be careful in your women of childbearing age. You want to get that negative pregnancy test. And I do want to just point out, just before I jump to the next section, when we're looking at Paxlovid, this is approved for individuals 12 and up. So don't let those high-risk individuals go without treatment. This is not just for adults. All right, Dr. Griffin, why didn't you mention Fluvoxamine?
You did last time, right?
I think last time I mentioned ivermectin. I'll make sure I mention that too. But what are the other options? What about Fluvoxamine? I hear at some prestigious medical center, somewhere in the middle of our country, that the docs there are giving everyone Fluvoxamine. Well, yeah. The paper Fluvoxamine for Outpatient Management of COVID-19 to Prevent Hospitalization, a systematic review and meta-analysis, was recently published in JAMA Network Open. And I do get asked this question a lot. Well, this systematic review is hopefully going to tell us what has happened so far. So the authors looked at a number of trials out there. They ultimately narrowed it down to 3 randomized controlled trials that together included 2,196 participants. They suggested that the relative risk for hospitalization was somewhere between 0.73 and 0.78, with a 95% confidence interval going from about 0.58 to 1.08. So they suggested there was moderate probability that Fluvoxamine given early could reduce progression to hospitalization by about 20 to 25%. Now, let's go into this a little bit because I'm a little critical of this publication. So the 3 trials they included were the Stop COVID-1 trial. This was 152 people, sort of a preliminary investigation. then followed up by Stop COVID-2 trial, which they included an N of 547. I will mention right here, that trial was stopped for futility, but they still included it in the analysis. And then they included the Together trial with an N of 1,497. So I just want to point out right there, 1,497. So this is almost a recap of the Together trial, but I'll go there again. So let's go through. The Stop COVID-2 trial was stopped for futility in May of 2021 after an interim analysis found that the low event rate seen in the trial was associated with a less than 10% conditional probability of demonstrating efficacy within an attainable sample size based on recruitment rate, right? So one of the things I want to say about this is this systematic review and meta-analysis, in my opinion, is really just a rehashing of the Together trial data. I don't think there's anything necessarily new here. This is one of those things where, boy, if I say it 5 times, it becomes true, and I'm not sure that it is. So fluvoxamine might be of limited benefit, might reduce progression to hospitalization by 20 to 25%, might also increase it by as much as 8%. This is certainly not in the same range as the 85 to 90% reduction we see with Paxlovid, monoclonals, or early IV remdesivir. It's even less effective than molnupiravir that we peg at about 30%. Now, the ongoing COVID out and Active 6 trials should give us more information. So if patients or clinicians are excited about fluvoxamine, they should look at enrolling in these trials. We also don't know the impact of these therapeutics with other medicines. So let's say you are offered Paxlovid, but you take this also. We're not sure what those interactions are. And certainly don't want to see people being given fluvoxamine when we have alternatives with proven efficacy. Now the early inflammatory phase, a couple exciting things here. So let's go through. So now the person, I just admitted an individual, I'm consulting on an individual who is being admitted, they progressed. They're now in the hospital. Their oxygen saturation is less than 94%, putting this person into that group where they are potentially a candidate for steroids. If they were above 94%, no benefit to steroids, right? So you want to give steroids to the right person at the right time and the right dose, which we've talked about. Anticoagulation, again, the dosing matters by severity of illness. Pulmonary support. If they're progressing on steroids, we might escalate to tocilizumab, which is undergoing FDA review for licensing. That's the monoclonal IL-6 receptor blocker. Some cases we might use baricitinib. But I've always sort of said that, boy, once people get to this point, once they get to the hospital, we just don't have impressive therapies to offer. Well, exciting news this week regarding a drug called sabizabutin. I'm going to have to work on that one. Sabizabutin. So this is a press release at this point. So more to come when we actually get to see the real data. But the press release comes from this company, Veru, V-E-R-U. Veru's novel COVID-19 drug candidate reduces deaths by 55% in hospitalized patients in interim analysis of phase 3 study. Independent data monitoring committee halts study early for overwhelming efficacy. Now, I know there's a certain cardiologists in the Twitterverse who's not impressed with this, but I'm going to go on and talk about what do we know here. So this is a once-a-day oral alpha and beta tubulin inhibitor. It's in this group of drugs that are considered cytoskeleton disruptors. So this trial was a phase 3 double-blind randomized placebo-controlled trial. It was actually registered with the FDA, so this wasn't just off there. They looked at once-a-day dosing of sabizabutin, 9 milligrams, versus placebo in hospitalized moderate to severe COVID-19 patients who are at high risk for ARDS and death. The patients were randomized 2 to 1, so 2 getting treatment versus 1 getting placebo. The trial was conducted in the United States, Brazil, Colombia, Argentina, Mexico, and Bulgaria. The COVID-19 infections treated in the study included the Delta and the Omicron variants. And they had a planned interim analysis when the first 150 patients were randomized into the study. The primary efficacy endpoint was the proportion of patients that died at day 60, right? So this is a very hard endpoint. It's death. There's no sort of subjective judgment here. sabizabutin treatment resulted in a 55% reduction in deaths with a p-value of 0.0029. Pretty impressive with such a small group. The placebo group was N equals 52. The treatment group was 98, so about 150. So we saw a 45% mortality rate. This is a very ill patient population, but only 20% in the sabizabutin. How am I pronouncing that?
Sabizabutin. It rhymes with Putin.
Okay. So, but how does this medicine work? And that's a little bit of a challenge here. Is it a cytokine storm treatment? Is it decreasing levels of certain cytokines? Is it decreasing macrophage activation? That makes sense. Of course, they're claiming it's the pocket knife, the Swiss Army knife. It's antiviral and anti-inflammatory. Well, I'm still waiting for the data to get that, but pretty exciting. If we can now actually, if a patient progresses to the hospital, and I like to use these numbers, vaccines, 90% reduction in ending up in the hospital. Get treated in that first week with something like Paxlovid, another 90% reduction. Now they end up in the hospital. This was on top of the benefit of steroid and all the other therapies, another 55% reduction. So one of the things I think that people are waking up to this last week is that COVID is not over. We are still going to see people end up in the hospital with COVID. Actually, next winter, we're expecting there to be significant numbers. We still need therapies in this space. And I do want to point out, this is not colchicine. I don't want people saying like, oh, this is just like a fancy form of colchicine. We have data on colchicine from the recovery trial. Those are our buddies over there in the UK. They looked at colchicine in hospitalized adults. So in adults hospitalized with COVID-19, colchicine was not associated with reductions in mortality, duration of hospital stay, or risk of progressing to invasive mechanical ventilation of death. So this is not colchicine. This is some other drug that I will learn to pronounce better in the future. All right.
So Daniel, it says a 55 reduction in deaths, right? 55%.
Yeah.
What would Paxlovid get you? 90%?
And different times, right? So Paxlovid, you're giving it in that first 5 days. Hopefully, you're giving the first 5 days 90% reduction, and then for anyone who ends up progressing to the hospital, this is sort of a different time window. This is the early inflammatory phase. Okay,
so this is not really an antiviral.
I don't think it's working as an antiviral. Yeah. I know they talk about it, and it's the cytoskeleton and it's the viral highway, and it's preventing. I don't buy any of that. I think it's anti-inflammatory.
Yeah.
All right, what about the rest of the world? SARS-CoV-2 infection in Africa, a systematic review and meta-analysis of standardized seroprevalence studies from January 2020 to December 2021. This was posted as a preprint. This is a meta-analysis of population-based seroprevalence studies to estimate the SARS-CoV-2 seroprevalence in Africa. They identified a large number of studies. What they found, I think this is important, is the seroprevalence was highly heterogeneous, looking in urban versus rural, looking at lower versus higher socioeconomic, really quite different between middle, Western, Eastern Africa. They found high seroprevalence in Africa, suggesting greater population exposure to SARS-CoV-2 than indicated by some of the surveillance data, but the seroprevalence was not uniform. And I sort of brought up some of the figures here, and you can see, Eastern Africa, you're actually getting pretty high levels, getting up to probably about 70 or more %. But then you start looking at other areas like Southern Africa might be a little bit different there. So, I think one of the concerns here is that I know some people have thrown up their hands, it's too late, a huge chunk has already been infected. There's still a huge chunk that has not had the opportunity, the access to vaccines. And here some parting words, which I sort of alluded to early on. When many people listen to this podcast, they'll be in the midst of celebrating a number of holidays, Passover, Easter, Ramadan. Think about making safe choices, limiting those group sizes, spending time together, perhaps outdoors. Think about testing, being thoughtful regarding those at higher risk as far as your plans and how you enjoy the holidays, and have a plan of action should someone test positive. Be ready to go. Talk to your providers know what to do. Practice those surprise faces next week when numbers start climbing, because everyone said it was over. But I want everyone to pause here, go to parasiteswithoutborders.com, click on that donate button. Every small amount helps. We want to continue to be here to provide you helpful information. And only a little bit of time left, only a couple weeks left here in April in our Parasites Without Border fundraiser for the American Society of Tropical Medicine and Hygiene. We're trying to get to $20,000 so that we can do a $40,000 donation. We're up to $15,178, so we only need $4,000 or $5,000 more. So help us out there. These are going to go to help support scholarships for females from low and middle income countries who might want to attend the 2022 meeting in Seattle, Washington.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Eben writes, my 6-year-old was just hospitalized today and diagnosed with pericarditis. Generally, he's a very healthy little guy. He was vaccinated with Pfizer last November, contracted infection a few weeks ago. Symptoms were mild. He had a low fever, briefly lost his sense of taste and smell, and he has been testing negative since April 1st. Today, he had a sudden spike in fever up to 104F while he was complaining that his heart hurt. It was racing when my wife put her hand on his chest. The ambulance took them to the hospital where an ECG revealed pericarditis. They sent him home for bed rest, and he will be getting a checkup with a pediatrician in 3 days. Basically, I'm wondering what the future might hold. I know we'll need to watch the situation closely for the next couple of weeks before he heads back to school, assuming everything's okay. But what about the prognosis for the medium to long term? Are kids like him recovering, or are some developing long COVID problems? Have there been any recent papers on this that we can check out? Do you know of any studies that are actively tracking this?
Yeah, so this is being actively tracked, and this is, it's tragic, right? You did the right things, you did the vaccination, and I do think, and this is something that I will say that's reassuring, is when we are seeing people get infected post-vaccination, the long-term effects tend to be less severe, they tend to be less prolonged. And this is certainly being studied, certainly being followed. We're finally, I feel like we're finally starting to get these trials out there. I was on a call last night with Survivor Corps where we were talking about doing a trial where we might look at using antiviral therapy, addressing that issue. Is there viral persistence that's triggering this? There's a lot of individuals looking at the immunology side of this. Is this some sort of immune dysfunction that we can somehow rein in? So that there's a lot going on here. But in most cases, I mean, a 6-year-old child is usually going to resolve. So I can be somewhat reassuring, but each individual is an individual, so they're going to do what they're going to do.
Charlie writes, my 75-years-old father-in-law is traveling in Pennsylvania and caught COVID. He's vaccinated and boosted last December. On day 3 of symptoms, only coughing and sounds hoarse. Oxygen sat 96%. However, he has serious heart issues, consequently some kidney issues, and weighs a lot higher than he should be. I thought with his age and health issues, he would be prime target for monoclonals, but the physicians who saw him waved it off. He said, his lung sounds good, O2 is good. I thought, sure, on day 3, but by the time things look worse, we run out of time. Am I wrong here?
So this is painful. And I think this really, everyone listen to TWiV 888, because I think that this is really critical for people to just get this hammered home. And obviously clinicians are not getting this, as we're seeing here, is you can't wait to see. The way this virus works is that first 3 to 5 days is when you see the viral replication. If you don't step in then and shut down that viral replication, a few days go by, and then you potentially end up in that early inflammatory phase. And at that point, our tools are limited. So you don't wait and see. You don't listen to the lungs. You look at this individual and you say, this individual is 75 years old. They're over 65. We have medications that can reduce their risk of progression by 85, 90%. If they're not comfortable, quote unquote, with Paxlovid, get comfortable. If the individual does not qualify for Paxlovid, go ahead and look at bebtelovimab. We have sites They'll even come to your house and give you this. And a lot of sites are actually doing the IV remdesivir. And last, if you're not going to do anything else, at least call in a script of the molnupiravir. So no, this is not the way we manage COVID. This is not in accordance with the ID Society guidelines, with the NIH treatment guidelines. Yeah.
In a similar vein, Jessie writes, my 85-year-old grandmother and her husband of the same age recently tested positive for COVID. However, they are reluctant to take Paxlovid until the situation gets bad for them. Her doctor told her she can make her own decision. At least that's what she told us, they said. What's the best material we can share that helps explain the importance of early action? A video would be great. Why aren't doctors educating their patients on this, and what can someone else do to help? Their at-risk family learn and be prepared before this happens. They live in New York City. Is the hotline going to help convince them, or is it only useful once they're committed?
Yeah, this is tough, right? I mean, when the patient calls their provider and the provider is just, oh, you can make your own decision. Really? An 85-year-old person is at risk of progression. Would you say, oh, I just got a blood test back, you've got some bacteria in the blood, most people, we recommend antibiotics. If you don't, you could die, but some people choose to just go ahead and, no, I'm not sure how physicians, how clinicians continue to approach this in such a cavalier manner. If you do not start the treatment during that opportunity window, it closes. So, we've done a bunch of things over time. You could maybe get them to listen to TWiV. I'm not sure how painful that is. They could watch it on YouTube. We actually early on, and this was with United Health Group, this was Survivor Corps and other organizations, we actually created these monoclonal windows, sort of trying to, it was like an infographic, right? And so I had a little avatar and I would tell you how wonderful it was to get those monoclonals early. Yeah, we need all hands on deck. If the providers out there are not educating their patients, if they're not advocating for their patients, if they're not communicating the urgency of responding in that window, yeah, our hospitals are going to start to get busier.
All right, for our last one, Daniel, I thought I'd try something different. This is a question about dengue. Philip writes, my Colombian wife had dengue in Colombia about 10 years ago, recovered well. She's planning a trip to Colombia soon. I see the dengue vaccine should only be given to people who test positive for prior infection. The vaccines given here seem to be given to youth. My wife is 68. Trying to figure out the dengue vaccine. She can either try a travel clinic in the U.S. or maybe in Colombia. Your thoughts?
Yeah, so I actually like that. This is gonna let me go into an area where I was harassing a patient about this Tuesday, and he's one of these, very, very excited about the natural immunity approach. And one of the things we were talking about is, let's talk about what happens when you get one episode of dengue and now you get a second episode. So in adults, most adults, they get that first episode of dengue, they get a rash, they get a headache, they get a fever, they feel crummy, they survive. But it's often that second infection by a different type of dengue where we get this antibody-dependent enhancement. A certain amount of time has gone by, the antibodies have gotten down to a certain level. Those antibodies don't actually neutralize quite as well. Actually, if anything, they bind the virus, allow it to be taken up into macrophages, monocytes, neutrophils, other cells with Fc receptors. This was actually discussed on a recent TWiV. And so one of my concerns, right, and I like dengue being brought up here, is that these people who got infected and now, I don't know, a year goes by, 18 months, I'm not sure how much time goes by, and antibodies get to a certain level, are we going to see a dengue-like effect with reinfections with COVID? It's too early to tell. But that's what you're seeing here, is we don't worry so much about individuals the first time they get dengue, but we're trying to protect people from this second infection where they have this antibody-dependent enhancement. But I will close and say, all that being said, a lot of people that die of dengue are children, and it's their first infection. So a little complexity there.
But this person would be a candidate for a vaccine, no?
Yeah. They should definitely discuss it with their travel provider.
That's COVID-19 Clinical Update number 110 with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you so much. And everyone, really be safe out there.